Topic today, growth hormone. Hello, everyone. Welcome to the TRT and Hormone Optimization YouTube channel. I'm Danny Bossa, joined today, self-proclaimed meathead from the UK, coach, and just happens to know a lot about growth hormone and a lot of other pharma. Please welcome Jeffery.
Welcome to this channel. I am Dr. Steven de Vos, the lifting dermatologist, and this is my partner Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe. I also invite you to join my other YouTube channel, The Lifting Dermatologist. The link you can find in the description of this video.
How are you, Joe?
Yeah, not too bad. Well, I say I'm not too bad. I've been really ill this week. So my apologies now. I'll apologize for the duration of this podcast. My brain definitely isn't working at optimal capabilities.
That's all right.
I didn't want to let you down on the day. So we'll make it work, man. It's cool.
That's okay. Don't worry. We'll let it go. Just don't let it happen again. I'm just kidding. Topic today, growth hormone. We've talked about TRT and pregnenolone and DHEA and all these other topics. We've never had any discussion whatsoever about growth hormone. Someone messaged me, and I'm trying to remember who it was, that messaged me directly, says you should really have Jeffery on talk about growth hormone. I remember.
Probably my wife.
Now your wife.
My one fan, yeah.
Anonymous request. This guy's really smart. And it's something we've never really talked about before. So Jeffery is, like I said, self-proclaimed meathead. He's just like us. He wants to put on some size and whatever. He's done a lot of coaching, so he knows a lot about growth hormone, how it works, what to expect, how much you want to take if you want to put on size, fat loss. Maybe we could touch a bit on replacement, that type of thing, just to give you guys a little bit of ideas. A lot of you guys have no real understanding how this stuff works. So thought I'd have him on, have a little chat, and that's it. Joe, tell me about growth hormone.
Okay, yeah, growth hormone. So I've done a couple of large podcasts in the past about growth hormone where we dug deep on. There was two that I did with a company called the Muscle Mentors, if guys want to check it out. I also provide their sort of biochemistry educational work over here in the UK. For anybody that signed up to their website and goes to their courses and stuff, I'm the guy that covers the chemistry over there. I will make the point now, as you said, that I'm not qualified to talk about any of this. I'm just absolutely complete meathead, just trying to get as big as possible. So that leads me down the research path of trying to understand these things the best I can. Anyway, if you really wanted to dig deep on them, I would suggest that you go and listen to those podcasts, because we went real deep into the chemistry, but we definitely can glance over that today. More importantly, maybe cover what the literature says in terms of growth hormone replacement. I've never covered that before, but it is something I have researched. It's an interesting area. And I imagine for the population listening to your podcast here, they're very much of the anti-aging crowd or the longevity crowd, the people that are maybe not necessarily trying to pack on the maximum amount of muscle tissue, but maybe looking to maintain a certain quality of life or longevity and stuff heading forward. So
that'll probably be I'd say predominantly what it is, but there is a lot of the meathead types that have come off of long-term steroid cycles they got on TRT, and they'll watch these videos, and we do touch upon a bunch of other topics as well. Whatever you care to offer, sir.
Okay, well let's run through what the research says about growth hormone replacement then. So, as I'm sure everyone is aware, as is the case with testosterone, that I'm sure you've spoken about a lot, multiple population-based epidemiological studies show an age-related decrease in both growth hormone and IGF-1 levels. The term that's used to describe that phenomena is somatopause. So essentially, as you age, your serum growth hormone, your endocrine IGF-1, systemic IGF-1, localized IGF-1, autocrine IGF-1, all of these isoforms of IGF-1 are going to drop down. It's kind of difficult when looking at literature to apply this to us. We split it into two categories, really, where on some literature, growth hormone therapy is given to otherwise healthy elderly subjects, which are going to be the people that are listening to this. And then other literature that's given to some adult onset growth hormone deficient people. So obviously healthy adults are the most applicable to us and anti-aging. But both of them are, in my opinion anyway, both of them are useful because they are essentially looking at people that are growth hormone deficient. What happens when we give them growth hormone? This is what happens, you know? So the research is fairly applicable, whereas in many cases, when looking at growth hormone for hypertrophy and stuff, it isn't, and there's some considerations to make there that we can go through as well. I mean, my first big consideration for anybody listening to this would be, I mean, I'm not sure how many women listen to this podcast, but growth hormone therapy is sexually dimorphic, and women respond really poorly in terms of serum IGF-1 to growth hormone.
Okay.
So women would certainly require higher doses of growth hormone for longer periods of time than men to likely achieve the same physiological replacement levels. So that would be a consideration, because dose dependence in terms of side effects, the more you use, the more side effects, but just to recreate that same physiological level, it's going to be a problem. So what's going to occur in this somatopause period? There's going to be negative changes to body composition. So maybe a loss of skeletal muscle mass, maybe a gain of fat mass. You have a decreased capacity to exercise, a reduction in quality of life. Your lipid markers might go off. Carbohydrate metabolism may go down. Poor bone mass, adverse cardiovascular risk profile. You know, it's nasty stuff that, I mean, we see that with testosterone as well, stuff, you know, all these declining hormone levels, essentially we're just moving towards death. You know, it's supposed to happen, but I suppose we can biochemically hack the system, so to speak, here. At what cost is probably the question that we're going to answer today. So replacement therapy with growth hormone came quite a lot later than testosterone. I think testosterone was, you'd probably know better than me, it was like the mid-1930s. Recombinant human growth hormone, so not extractive human growth hormone, the recombinant human growth hormone, has been available since the 1980s. And the research and experience collected in that time since then is huge. And it does clearly demonstrate the reversal of the majority of the negative implications of being growth hormone deficient. But again, on the flip side, chronic growth hormone use is not without risks. So maybe we go over, I mean, you let me know how this sounds to you. We go over the benefits.
Sure.
And then the risks.
Sure. Absolutely.
And then the listener, it's really up to you and your ethics. You know, say the same about testosterone. Like, hey, look, if I take 2 grams of testosterone a week, you know, I'll probably add some good muscle tissue, but, you know, a lot of my health markers could be negatively affected. But is that risk to reward ratio worth it to me? Mm-hmm. Same thing, you know, this inverted U response, it does more up until a point, and then the sort of negative health implications are going to overtake that. Mm-hmm. So benefits.
Absolutely.
Most obvious one, everyone knows this, body composition. So treatment with growth hormone will cause a decrease in overall fat mass. So you take growth hormone, mobilize free fatty acids, assuming you're in a calorie deficit, you're going to oxidize them. There's semantics here, like more free fatty acids will be mobilized in a fasted state. So presence of amino acids, dietary fat, as in free fatty acids, blood insulin levels, blood amino acid levels. These will all attenuate the amount of free fatty acids you can mobilize. Again, like the rate of mobilization, we go into deep on that podcast with the muscle mentors, but as sort of a blanket recommendation, dose-wise, to maximize free fatty acid mobilization, you're looking about 1.5 IUs per kilo of body weight, and that's shot IV. So maybe a little bit more if you're doing a subcutaneous or intramuscular shot. For most people, you could make a blanket statement like 2 units is going to maximize the free fatty acid mobilization.
1.5 IU per kilo?
Yes.
Per day?
Per period of injection. So per amount of time that you would be mobilizing those free fatty acids. And
okay.
That can go on for quite a while. I think it starts to tail off about the 2-hour mark from the top of my head. So maybe if you were 3 hours fasted and you did that, you'd have maximized your fat loss in that time.
Okay, so I'm trying to wrap my brain around the math, and maybe we ran out of espresso coffee, so I'm a little.
I'm actually sipping a pre-workout to get me through this.
So, like I've read a lot of guys will take, the guys doing replacement, they're doing 1-2 IU a day.
Yes.
Then you got the other guys that are doing 4 to 6, 7 IU a day, 4 to 6 IU a day. I was always told that once you're getting in like over 6 IU a day, that you're getting into like pretty, you can say pharma type doses. Is that? But now you're saying 1.5 IU per kilo of body weight. But again, over what is the period of time? Like, how do you?
That would be per administration. And this is also where we could get into dosing considerations of each administration and what effect on which isoform of IGF-1 is that going to have. So you could shoot 10 units of growth hormone in one shot.
Mm-hmm.
Above that, let's say 2 IU dose. If you were a 100 kilo male, you shot 10 IU in one shot. The 8 IU would not increase the amount of free fatty acids mobilized. However, there would be a dose-dependent increase in systemic IGF-1.
Okay.
Now, this gave birth to the boom dose theory of growth hormone for hypertrophy. However, I believe that to be a misunderstanding based on how IGF-1 can drive hypertrophy, because it isn't systemic or endocrine IGF-1 that drives hypertrophy. Rather, it's localized autocrine and paracrine IGF-1 within the muscle cell itself. And there is evidence that systemic IGF-1 can actually act as a negative feedback regulator of that localized IGF-1. So my consideration here would be to be aware that most of the side effects you're going to see are going to be via higher IGF-1, talking whole body systemic IGF-1, and that can also have a negative implication on your hypertrophy goals. And it's also providing zero additional benefit in terms of a lipolytic, i.e. fat loss driven occurrence there. Not my recommendation to dose so high.
Okay.
So sorry, because I went off on a tirade there, but to go back to fat loss, let's say we had a 100 kilo male. He'd woken up in the morning, so he was sufficiently fasted to inject growth hormone and therefore mobilize free fatty acids. He would require 1.5 IU of growth hormone to top out the amount of free fatty acid mobilization that he could get, assuming he was injecting it intravenously. Subcutaneously, it's going to be slightly less bioavailable. We could say 2 units as a fairly sure assumption that would maximize his free fatty acid mobilization there. So anything above that would not increase the rate of fat loss during that active window of free fatty acid mobilization.
Okay.
So maybe 6 hours later, 8 hours later, he could administer again and reset, although unlikely that anybody's just fasting all day. Not to say that he wouldn't get some mobilization effect or some metabolic effects that will drive lipolysis, because you will. It's just a sliding scale.
Okay, so we're talking 1.5 to 2 IU per window, as you were describing there.
Yeah.
Because earlier I thought I had understood 1.5 IU per kilo. Perhaps you were saying per window, and I understood.
Yeah, no, per kilo, that would be correct. So you could base, as we would measure androgens, we're looking at milligram per kilo. So if you're looking at like the Anadrol research, 2 to 3 milligram per kilogram per day is a prescription for burns victims.
But in a 100 kilogram male, if he was going to be taking 1.5 IU per kilo, that's 150 IU.
Am I 1.5 IU per 100 kilo. This is me not thinking correctly. Yeah.
Okay, so that's what I wanted to check. People are like, damn, my growth hormone bill's going to get expensive.
Well, see, this is my brain not working correctly today.
Okay, I wanted to check. I was going to let it go. I said, maybe I'm just like slow, and he'll clarify later.
My apologies. That's my mistake. So it'd be 1.5 IU per 100 kilo. Yeah.
Gotcha. Per 100 kilo. Okay.
Yeah.
That makes sense. All right, we're good.
So we could divvy that up through the day, as I said, but there would be a sliding scale of poor returns. And the drop off of free fatty acid mobilization when there is presence of amino acids or glucose or insulin in the blood is pretty huge. And obviously you'd be above replacement dosages by then also.
And in regards to the fasted part, so you're taking it when you're fasted, or you're taking it when you know you will be fasted afterwards? So let's say, for example, I wake up in the morning, clearly I'm fasted.
Mm-hmm.
That would be the time to take it?
Yes. Yeah. There is some evidence that bioavailability of growth hormone is greater pre-bed at nighttime.
Okay.
Whether this is some kind of chronotyping of pharmacology I haven't really dug into. I suppose there'd be efficacy there, but it makes sense. Consider how we have evolved to secrete endogenous growth hormone at nighttime, that there would be a higher bioavailability. So you could take it pre-bed, but you would have wanted, if you're looking to maximize fat loss, to not have eaten maybe 4 to 6 hours prior to that administration.
Okay, gotcha.
And that would maximize the free fatty acid mobilization potential.
So the approach of splitting it up and saying, I'll just take half my dose in the morning, take another half before bed, that's probably a good practice then.
Yeah, that's very common. Yep. Okay. Either one, just once in the morning, or, once AM and once pre-bed. That's something I've done with clients for years. Anecdotally, has worked really well. The benefit of putting it in the morning is you can then include some kind of non-glucose intensive activity, like walking your dog, and that will greater potentiate the amount of free fatty acid mobilized in that period. Okay.
And sometimes in the US, walking the dog means something else, but I won't. I won't go there. How quickly let's say someone that was going to do that, someone that says, okay, I'm going to take, 1.5 IU when I wake up, 1.5 IU before going to bed. Mm-hmm. Specifically for fat losses we're discussing, how long does it typically take for one to see benefits of that? Because I get a lot of conflicting opinion on that. Some people say, oh, you need to give it 6 months to really see anything that growth hormone is doing and that type of thing. I know other guys that have got pharma grade growth hormone, and other guys that got, they got generic brand growth hormone, and they're all like, well, we're going to have to wait and see over a period of a lot of time if it's actually legit or not, if it's having an effect.
Yeah, I had this conversation with somebody on a consultation the other day. Like the adage that it takes 6 months for growth hormone to start working and stuff like this. No, it's active upon injection. And there's also a highly biologically inter-individual component of, 1, how many free fatty acids will you mobilize in that time? And then 2, on an individual to individual basis, are you within shooting distance of being lean enough to notice relatively rapid changes anyway? And 3, how large is your relative deficit in respect to how many more free fatty acids you'll be mobilizing? And will that then potentiate your effect so much for you to rapidly see it? So it's hard to give a blanket answer, but actually in terms of net effect, it has a large net effect on lipolysis. Is huge. I think it's often discounted, likely just because people aren't following a protocol that would maximize the use of growth hormone for fat loss. But when used properly, just from my experience with working with people over the years doing these kind of protocols, is that they would notice it very, very quickly, if coming from a place of not doing so prior.
Gotcha. Okay. All right. So obviously then if we're going to talk about guys that want to do it for hypertrophy, it's going to be a significantly higher dose there. Do you have a general guideline for I know this is more of a TRT forum, guys, but we're on the subject. We might as well just to get up kind of a point of reference.
I mean, much like with anabolics, it's a dose-dependent factor. However, growth hormone in and of itself doesn't cause increases in skeletal muscle mass. There's no evidence of that. And this is something that we could also get into on the resistance training, not the resistance training, sorry, the replacement therapy. I got the RTs mixed up there. The replacement therapy window as well, because that's one of like the contraindications is like the increase in lean body mass. Don't be confused that lean body mass doesn't necessarily mean muscle mass. It can. In the case of growth hormone, it doesn't. It means fluid retention, extracellular fluid.
So this is more a result of just body recomposition.
Yeah, no one's gaining any muscle from using growth hormone. However, there's a unique synergy when you pair growth hormone with anabolics. So let's look at what testosterone does. So testosterone is going to increase mRNA expression of localized IGF-1 inside of the muscle cell itself. And then when you use growth hormone and then downstream the creation to these localized IGF-1 factors, you will then see a higher free level of IGF-1 that will contribute to hypertrophy there. So to summarize that, we're looking at increased mRNA levels of myosin heavy chain IGF-1 receptors in skeletal muscle tissue. And that increase of intramuscular IGF-1 mRNA expression and a decrease in IGF binding protein, I think it's either 3 or 4, I think it's 4, lead to an increased level of free IGF-1. And we see hypertrophy that way.
Okay.
So growth hormone used without anabolics for hypertrophy is a fool's errand. Again, if anyone wants to go like super deep on this, we do go into this on that Muscle Mentors podcast. But like as a whole, it's not something that I would necessarily chase if I was looking for hypertrophy, unless I was using a super physiological dose of androgens already. And then you get things like greater androgen receptor density with growth hormone. Again, they just synergize together really well. So growth hormone will increase whole body protein synthesis rates, increase transport rates for leucine, increase hepatic IGF-1 production, decrease the rate of amino acid oxidation. And all these things synergize with what anabolics do really well.
Okay.
In terms of dose considerations, like how much can you afford? You know, it's more is more, you know, same thing with anabolics, but until it isn't. And
yeah, there's a point of no return at one point.
Yeah, and it's going to differ.
There are a point of diminishing returns, I should say, sorry.
Yeah, and that tail off is going to be so far away from each individual. But I think there comes a point where without adding insulin to the equation, you're at a bit of a fool's errand. And in my experience, it's somewhere around that 8 unit mark. Anything over 8 IU a day, if you're just using anabolics and you haven't got insulin in the picture as well, you know, there could be a bit of a fool's errand to push that any higher. And also, I mean, you're getting into the category of really struggling to control the hyperglycemia from higher doses of growth hormone anyway.
Right.
At that point. So without insulin and trying to push food in to grow, you could be in trouble.
I've had so many talks with guys that they were under the impression where growth hormone was something you take to grow, because it's growth hormone, right? And then back when I knew zero on the subject, I kind of thought the same thing. Growth hormone, you take it and maybe you get changes in even in your skeleton or in your facial features, or it's to grow. And then when I started looking into it, not all that long ago, really, because we were all just focused on the testosterone stuff, I started learning that, you know, it doesn't really have that effect. It's not something you take to just gain muscle. It's more going to be for, like we were saying, body recomposition and whatnot, and can accentuate, like you're saying, some of the things you take. But that was always a misconception I had for the longest time, that, you know, you could just take growth hormone just to get jacked, basically.
Yeah. I mean, it's a fair enough name. And I know that you hear about hyperplasia is a great example, you know, or bone growth and organ growth, stuff like this. I mean, there's no evidence that this stuff happens outside of the perinatal period. So yes, growth hormone will drive those adaptations in the perinatal period, but us as adults using growth hormone, they're not considerations. Hyperplasia, I've never seen a paper, and trust me, I've looked, that can see any level of hyperplasia from growth hormone, let alone anything, to be honest. I think those stretch studies that are done on animals, compensatory hypertrophy mechanisms models, show hyperplasia, but never have I seen it in a human, let alone from a drug yet. So that wouldn't be a
what are your thoughts on the subject has come up in our Facebook group quite a bit, and people are, they're seeing the astronomical cost of what, true pharma grade HGH is. For some people, they're just blown away by it, considering how inexpensive testosterone is. What are your thoughts on, the different types of growth hormone we're seeing, on the market on these websites, that some is pharma grade, or some is generic, or some is Chinese, or some is whatever else? Are there generic non-pharma grade growth hormones that you can take that are acceptable, or potentially that you have to just take in a higher dose than true pharma? Is there some you should stay away from entirely? Should you be sticking strictly to pharma?
Let's draw a comparison to testosterone, like an underground lab testosterone. You have the molecule, the testosterone molecule itself. It's a testosterone molecule. You have growth hormone, you have a growth hormone molecule. As long as there's no, and this is a consideration, as long as there's no mutations to the growth hormone molecule, or it is overly dimerized, which is essentially when two of the molecules stick together, they can cause an immune reaction. It's going to do the same thing, right? Assuming that's what it is. And it's no secret that recombinant technologies is fairly available now. There are factories in China that will produce quote unquote pharma grade growth hormone, and you can send this off for HPLC testing and see the amount of dimer, see the purity. And a molecule is a molecule. I know this is still going around in the bodybuilding world, like generic doesn't act like pharma. It's the same molecule. It can't not act the same way. If there was a mutation in the molecule, yeah, okay. If it was dimerized, yeah, okay. But these things can be tested for. Are there awful generics out there? Yeah, there's generics that I've seen that have come back with, vasopressin in it, which is a nasty antidiuretic hormone that's used to essentially dry fluid retention onto people to make them think, yeah, this growth hormone is amazing. Look how much fluid I've gained. Must be real, and this crazy stuff, or like badly dosed, or obviously there was a huge immune reaction within the UK to people that were getting hydrotropin a few years ago, and they all got welts because there was obviously some nasty mutations there. But these days there are genuinely good generics. This is by no means a recommendation to go and buy it, because of course you're better off buying an FDA approved drug that's been created in a GMP compliant facility, etc. But it is no secret that there are many HPLC testing facilities that are testing these generic growth hormones now. I mean, you could go and look on Professional Muscle Forum. There's lots of companies that have threads dedicated to HPLC testing their generic growth, and they'll post up exactly what it is. And the molecule is the same molecule at the end of the day. It's going to do what it's going to do.
Mm-hmm. As long as that actual molecule is in it.
As long as it's in it and it is intact, yeah. And has survived the trip to you. And I mean, the growth hormone molecule, I don't think is as labile as some people would make out. If it's like lyophilized, so it's a freeze-dried powder, it makes its way to you from China. They're not, and it's not going to go under any extreme heats, and it's been vacuum sealed in such a way that the powder won't move. It's going to be fine by the time it gets to you. So I know it's an
extreme cold.
Sorry?
Actually, yeah, or extreme cold. Let's say where I live in Montreal, and it shows, you guys up and live in Canada, and it shows up in the mail, and it's, minus 20 degrees outside. But that stuff is freeze dried, right? So the cold shouldn't really have.
No, the cold wouldn't. I mean, maybe if you ordered anabolics and they were crashed.
It's probably only once you've actually reconstituted with the bacteriostatic water at that point. I know that you can't freeze that or.
See, I don't know if you can freeze reconstituted growth hormone, but I know that there's a bit of a focus on keeping reconstituted growth hormone cold. I'm not sure if that actually needs to be done. I think room temperature is actually fine, because I know a lot of pharma solutions do say just keep them in a cool, dry place. So I'm not too sure on that one. But yeah, generic versus pharma, it's just going to continue the way that everything goes, that people out here are trying to make money and produce a good quality product, just like anything else. These guys won't repeat business. They're not making crap for them. I mean, as much as they can. I'm sure some people are, but yeah.
Unless it's just a short-term scam, sell a bunch, and then, see ya, suckers. But even with, because I took HCG at one point, and it's kind of the similar type thing where you get the little powder and you add the bacteriostatic water. It's still, they're all considered peptides, and on the label it said specifically keep it in the fridge, do not freeze. So I always assumed that growth hormone was the same. What about age? Do you have any guidelines as to, the younger guys that are, late teens, and they're like, oh, I want to take stuff. Is there guidelines like, hey, if you're under a certain age, like, just don't touch the stuff at all?
I mean, again, that's such an ethical consideration. I can't necessarily give like an evidence-based answer. I mean, it would depend on what their goal is. Like, if they're saying, I want to take enough growth hormone to put me smack bang in the middle of the physiological range, I say, well, what's the point? It's like taking TRT when you've already got an 800 nanogram per deciliter testosterone, like an endogenous serum. But if their goal said, Joe, I want to be an IFBB pro next year, I'd say, oh, okay, well, maybe that this is a necessity, Age isn't something when you outside of the replacement guidelines. It ultimately is, to me, an ethical question. It's always hard for me to answer things like that, because ultimately,
what about from a suppression side of things? Like we always tell the young guys, you don't want to do testosterone. Take testosterone because maybe you wind up doing a cycle. You suppress your natural T, and now you're deficient, and now you got to get on TRT at 20 years old because you wanted to screw around with testosterone. Does growth hormone act in the same way that if you're using it, that there can be suppression of some kind?
So there's one trial. They took healthy male subjects and gave them a subcutaneous shot of growth hormone. And it was at 9 p.m. Varied dosing. So they were split into 0.01, 0.025, 0.05, or 0.1 milligram per kilogram dosing. Off the top of my head, I don't know what that is in units. All dosing groups demonstrated a complete suppression of endogenous growth hormone secretions, but it was only up to 24 hours.
And then it comes back.
Yes. So there was.
So say use a guy like me. I decide I'm going to take growth hormone. I'm going to do replacement. I've taken it for 2 years. And after 2 years, I'm like, I don't really think it's doing much with me, and it's expensive, and the hell with it. And I stopped taking it. Would my natural growth hormone come back to life on its own?
Well,
do I go through a period of suppression like I would maybe having taken testosterone for that length of time?
No, I mean, as long as you had a functioning pituitary gland prior, and whatever your endogenous output was, it's going to be, the same, but you've probably aged so a little bit less than it was prior. But you're not going to have a permanent negative feedback regulation there, no.
Okay, cool. Anything else we didn't touch on here?
Well, I could roll off the benefits of growth hormone. I think we spoke about body composition.
Yes.
So, yeah, decrease in fat mass, increase in lean mass. A paper from Bornson et al. It was on 156 patients. There's an improvement in lean mass that was sustained for 15 years. But the fat mass decrease was rapid and initial, wasn't continued. I imagine the issue with the long-term studies is that the aging process just attenuates the beneficial effects of growth hormone on body composition. And the literature, like we said, is on those that were previously growth hormone deficient. So maybe if we're coming from a point where we weren't coming from a state of deficiency to homeostasis, we might not see that effect. There was a recent meta-analysis It had 22 trials in it, and lean body mass increased by 2.61 kilo as compared to 0.04 kilo in the placebo group. But does that mean they gained muscle? So, no. Fat mass was decreased by 2.2 kilo, I think, in the growth hormone group, as compared to 0.3 kilo in the placebo group. So quite clearly, fat mass decrease is large. Like we were saying, what level of effect is there? Well, 2 kilo of fat mass lost in people that weren't even controlling for calories. That's pretty damn cool.
Yeah.
And they were dose-dependent responses. So the research did show that tissue hydration was increased with GHUs, but not skeletal muscle tissue. So that where people get caught up on this is this differentiation between extracellular fluid and intracellular mass. And the studies that do, there's one that was giving male subjects a 0.2, I'm going to try and get this right, IU per 100 kilo. No, per 1 kilo, or per 10 kilo. Basically, the 100 kilo male would have about 20 IU of growth hormone.
Okay.
It was a huge dose that they were using in this study. And they were looking at markers of skeletal muscle tissue. Now, I'm bastardizing this because I can't remember the reference, but if anyone wants to see it, let me know, because I shared it on Instagram when I found it, but it was a few years ago. I can find it for anybody that's listening that wants to see it. But it was looking at markers of skeletal muscle mass, and there was no change. So, who is even using that much? Are even IFBB pros using over 20 IU? Most cases, not the pros that I know, and there was zero skeletal muscle mass. So if you're going down that road, I wouldn't bother.
Yes, there must just be a point of diminishing returns, that you're pushing it past a certain point, and it's just, you're just burning your cash, basically.
Yeah, and especially if you're buying that pharma stuff. 20 IU a day. It's a big burn. Bone, talk about bone. Bone's something that people ask about. Asian people worry about bone mineral density. So GH in adult patients with growth hormone deficiency does increase bone mineral density around 4 to 10%. Two recent meta-analyses show that the increase in bone mineral density is related to gender, age, dose, and duration. So this is back to what we said about women. Women on estrogen replacement therapy do have a greater increase in bone mineral density. Likely not a surprise to most people listening to this, knowing that estrogen in and of itself does increase bone mineral density. And actually aromatase pathway stimulation drives growth hormone and IGF-1 axis stimulation. And we could go down the road here that why is testosterone such an effective drug? Why do people use testosterone? Why do pros use so much testosterone? Hey, on paper, nandrolone's, just as anabolic, blah, blah, blah. Hey, well, these people are also using growth hormone. What happens when you pair the two? Huge aromatase pathway activation, big increase in growth hormone serum, and all of the both lipolytic and anabolic pathways that's going to drive. There we see some clues there as to why bodybuilders might like testosterone.
Because of the estrogen they're getting from it.
Exactly. Estrogen is like 50% of why testosterone is so good, Can
you say that again, just louder?
Sorry, man. I have a habit of just like blurting.
No. I heard you, but I want the viewers, I want you to listen to what he said again. Say that again, please.
Okay, I'll try. Which bit do you want? So
about estrogen being.
Yeah, so estrogen is both highly anabolic in under multiple pathways. I've written about this on my Instagram again, and how it can relate to like beta adrenergic system stimulation, etc. Aromatase pathway activation drives growth hormone and IGF-1 pathway stimulation. So more aromatization is essentially going to mean a higher growth hormone serum, a higher amount of free IGF-1. This is why people like testosterone, in my opinion. Pair testosterone and growth hormone, you have, and insulin, but that's another topic. We have this holy grail of anabolism, essentially. And partly why, I might go so far as to say mainly why testosterone works so well is estrogen.
Mainly why testosterone works so well is estrogen, guys. Because I know we've just met, Joe, but I go on a warpath with people that are trying to block the estrogen. And they're like, I have this issue now, and I have this issue, and I've got erectile dysfunction, and my joints hurt, and this, and they're blocking estrogen. And I'm like, why? No, you want all these things. That's what estrogen does. Estrogen fixes all that. No, but I have to keep my estrogen in this range. And we go on and on. And then I get all these doctors come on, and they're talking about why you should never block estrogen. And these guys on the forums sometimes that I get onto, they think it's just opinion. I'm like, it's not. Here's another guy that says that estrogen is good for you. Okay. Yeah. Sorry. It's like this running gag on this channel with the amount of discussion we've had about estrogen, how good it is for you. And we still have these people that insist that definitely. No, you've got to keep it down at, raise your T, raise everything else. But estrogen is the boogeyman. Estrogen will kill you. Estrogen, you want to suppress it. And it's insane. Yeah,
it's really odd. I get a lot of consultations with people that will send me blood work. Like, look at this, my testosterone's 5,000, but my estrogen is like 80. I'm like, yeah? What? You've got super physiological testosterone and you're surprised that your estrogen is super physiological. Androgens and estrogens need to be kept in a specific ratio. If you have high testosterone levels, trust me, you should have high estrogen levels. Is how this axis functions. And if you have estrogenic side effects with higher serum estrogen, reducing the estrogen is probably a greater evil than increasing the androgen via maybe a non-aromatizing, or that there are other conversions to estrogen metabolites like estrogen at the androgen receptor. So I could say non-estrogenic androgens, maybe using them instead of an aromatase inhibitor would be the lesser of two evils here. Especially if you want to gain muscle, trust me, you want estrogen.
Funny how that works.
Yeah, is it funny though?
I mean, for them, it's estrogen. Yeah. That's the woman hormone. That's the one that's going to make you look like a woman. I want to look like a man, so I don't want any of that woman stuff. That's the mindset. It's crazy. It's crazy.
Well, yeah. On that note, higher estrogen leads to greater bone mineral density and higher growth hormone serum in this paper. So you want more bone mineral density. We want to move heavier weights, don't we? We want big, thick bones for long times. Old people fall over and they break bones.
And it's funny because that's commonplace in, with the IFBBs, all the pro bodybuilders.
Yeah.
They were doing that for years. I think it's becoming less and less commonplace now.
I'd agree. There's more. I consult with more competitive bodybuilders that are instead controlling their stack design, so to speak. So maybe using a masteron with their testosterone, as opposed to using an aromasin or a Arimidex to control any potential estrogenic side effects. It's more common now, which is good. I mean, things should be progressive. So my mum is a personal trainer. She works with the elderly, and the biggest thing I hear from her is people breaking bones. It's supposed to happen as we get older. We're supposed to fall over and hurt ourselves and eventually die. But I suppose we could, better living through modern medicine, we could control that. So that's bone. Maybe cardiovascular risk. That's what people worry about. So growth hormone does appear to improve several CV risk factors: lipid profile, endothelial function, and markers of cardiovascular inflammation. So studies have shown an increase in HDL and a decrease in LDL occurs with the use of growth hormone at therapeutic dosages. So big thumbs up there. Ceasing use of growth hormone for 4 months after 3 years of consistent use shows an increase in both total and LDL cholesterol in one paper from Philipson et al. So if you've been on growth hormone replacement therapy and then come off, these individuals' total cholesterol went up, as did their LDL. LDL likely still being the most important predictor of CV risk in terms of what we know on lipid profiles right now. That's not good news.
So if you get on, stay on.
Yeah, not my professional recommendation, but
get a loan. Go bug your dad. Go bug.
A meta-analysis of placebo-controlled studies also shows a decrease in diastolic blood pressure. Another good thing. So we mentioned inflammatory markers. I'm guessing everyone here knows what C-reactive protein is. CRP. It's made by your liver, sent to your bloodstream in response to inflammation. That reduces with growth hormone use, as does TNF-alpha, which is tumor necrosis factor, so cell signaling protein that's again involved with systemic inflammation, and interleukin-6, which is a pro-inflammatory cytokine that drops as well. So all of those markers of inflammation go down. Inflammation, we now know being one of the biggest predictors of disease. Some more thumbs up for growth hormone there. I think that maybe that's it for just benefits off the top of my head. There are some random things, like I was speaking to a friend that's writing a book on sleep. I did find a study from Morcelli et al. That 4 months of growth hormone therapy did reverse sleep disturbances in some of these people when using growth hormone, but they were growth hormone deficient prior. But, you know, if you're of a certain age, you could very well be growth hormone deficient. Coronary flow reserve and left ventricular diastolic function increases with growth hormone replacement therapy. Anaerobic capacity and physical function increases, interestingly, in a time-dependent fashion. So the longer that these people were on, the better it got. That's benefits off the top of my head. There are some risks. So this is where the question of at what cost comes in. I don't know if you want to run through the risks now.
Sure.
Okay, so a lot of studies include things that the participants complained about. A common one is actually the body composition. Increase in BMI, increase in waist circumference, just fluid retention, side effects, individual responses can be huge. Some people can get a massive amount of fluid retention or carpal tunnel. So edema, carpal tunnel derived from fluid retention occur in about 5 to 18% of the patients. Typically, though, when the dose is reduced and maybe slowly move back up in the future, you often see this like 2 unit and then a pull back to 1, then eventually a push back up to 2, usually improves. That's it in terms of body composition. Most people like it, but there are some complaints there.
We find that with testosterone as well, often enough. They're starting at a higher dose. They've got issues. They bring the dose down. The issues go away, and they slowly work their way back up. And now they're back to the original dose and no issues. Yeah.
The funniest one on testosterone is like people complaining about libido. Like that's a genuine contraindication on a lot of the studies where people say like, you know, my wife wants to divorce me because I can't leave her alone and things like this. It happens on female replacement therapy as well. Talking about women, they actually tend to have a higher rate of side effects, particularly this soft tissue edema. But like we said at the beginning, they're going to need more. So that's probably where that is there. Sorry, women, again, you get the short straw. CV risk, there are some actual increases. So lipoprotein A, which is a marker of CV risk, does increase with growth hormone use. And one study from Oliveira et al. Showed an increase in atherosclerosis plaque after 6 months of treatment. There's not great causal links, if I'm being very honest, in those research papers. The majority don't tend to show that. The biggest risk, in my opinion, hyperglycemia. So growth hormone use will reduce insulin sensitivity and it will elevate blood glucose. One study from Florakis et al. In 90 patients on growth hormone replacement therapy showed a significant increase, I might say, in blood glucose and HbA1c levels within 6 months of treatment and persisted after 2 years. So it doesn't normalize over time by the looks of things.
Should people like this be considering growth hormone with something like metformin or berberine in conjunction to keep it under control?
This is where we're seeing, especially in America, a lot of the anti-aging clinics using metformin, using GDAs like berberine, but also now using basal insulin analogs like Lantus, tend to have a great efficacy and probably a part of the anti-aging stack design you could say would be, in my opinion, a basal insulin like a low dose 24-hour insulin analog to keep your blood glucose, you know, assuming that you're not just being hyperinsulinemic and keep pounding food and just use it to control, or rather synthetically control an artificial increase in blood glucose with food. Like, you would still want to correct the underlying resistance by whatever mechanism you can. But yeah, most people would be wanting to use a metformin or a basal insulin or something like that to control that there. And it is pretty commonplace now, at least from what I'm seeing in the sort of biohacker field of people that are generally using. I mean, insulin has turned a corner in the last 5 years from what I've seen, from being the devil's drug to being something that can be quite intelligently used to increase lifespan, etc. Avoid insulin resistance, which again, alongside inflammation, is a huge predictor of disease risk, mortality, etc. I mean, it's that simple. Take growth hormone. It's a survival mechanism. It's endogenously secreted in periods of fasting, so it's going to drive up blood glucose. There's not a lot you can really do about that other than control it the best you can. And that would just be one of those things, like, and it's highly biologically into individual as well. Some people I've worked with, they don't get any blood glucose increase from 1 or 2 units of growth hormone a day. Not like a lot of the GHRHs or the GHRPs tend to be awful for that, especially MK677.
Yeah.
I don't know why, but maybe it's the long active life. Maybe, I don't know. It's just, it's got a pretty dreadful effect from, I don't think that maybe that's necessarily been studied yet. Maybe it has. Actually, what's just coming to my head, what people often ask about, is the cancer risk of growth hormone. We could go into that quickly if you want. There's not a lot to say on it.
Is there a risk of cancer for growth hormone? That one I haven't heard
cancer
about.
risk, or neoplasia, which is essentially the formation of new abnormal tissue growth, is a concern. So humans with chronic elevations of this not localized endocrine IGF-1, so whole body systemic IGF-1, they are at an increased risk for abnormal growth. So this neoplasia, whether that's benign or malignant. So the thing is, many tumors do express a high density of IGF-1 receptors, but some don't. And there's lots of conflicting data on this one. Epidemiological studies have suggested an association between higher serum IGF-1 or higher serum growth hormone to incidences of cancer. However, no actual causal link yet has been established. There was one recent study that was just over 400 patients with non-functioning pituitary adenomas. And there was 4,500 patient years of follow-up. So it's pretty big. And there was a reduced mortality in the growth hormone treated patients compared to the general population. And there was no increased death due to malignancy in that. Also, recent meta-analyses, including 2 retrospective and 7 prospective studies with over 10,000 patients included, actually showed that growth hormone replacement therapy reduced the risk of cancer in adults.
The only time I had really heard of something touching this was, let's say a guy's got, if he maybe has prostate cancer, the beginnings of prostate cancer, they would say, don't take growth hormone because it could exacerbate it and just accelerate the process.
Yeah, exactly. So that prostate tumor growth could have a high concentration of IGF-1 receptors, and your higher serum IGF-1 could bind there and proliferate and cause growth. I think because of that, I would say growth hormone therapy should definitely not be given to people with any active malignancy, and just used in caution with people with a history of cancer. Because you don't like catch cancer. Like, cancer grows when the environment is correct, and whether you feed it or not will really determine on whether it becomes an issue. Also, I suppose childhood cancer survivors could be at an increased risk for a secondary neoplasm compared to general population. But for just average people like us that don't have an active malignancy, it's probably not a concern. And as I say, still no causal link that at least I can find of actual growth other than fueling current growth that does have this active IGF-1 receptor dense area in it, you know?
So at the end of the day, it just comes down to a lot of the same thing of you could take this stuff, you could probably get some immediate benefits. It'll, you know, like the testosterone will be the same thing. I actually want to do a video discussing this. You know, if I'm doing this today at, you know, I'll be 46 years old next week, you know, what am I going to be like when I'm, let's say I get to 80 years old? Am I going to look back and say, why the hell did I do these things? Or is everything going to be great? Like, I don't know how long of the studies. I mean, frankly, guys on TRT. I mean, this is it's a new thing people are doing these days. We weren't doing TRT in the 1930s or 1940s.
Oh, for sure, man.
Now,
I mean, only since,
you know,
like the mid 80s, and that at least we've got good literature on. And I just turned 26 like 2 weeks ago, so I've got, you know, this is why I'm trying to dig into this, because, you know, we're generally trying to draw what we can from a lot of mostly poorly conducted literature, and just trying to create correlations to causations between these things, and hypotheses on what might happen. But you're wise to do so, I think. So like we're talking about lifespan, I think much like testosterone, the benefits are going to be somewhere in the happy medium. So this inverted U response, like we spoke about. So there's benefits on recovery from body composition, maybe muscle growth if using anabolics as well, potentially sleep, things like that. But there's definitely detrimental sides to being bigger, heavier, and taller that have been shown in literature when it comes to lifespan. And low levels of IGF-1 translate into an increased mortality risk in the general population, predominantly due to an increase in CV diseases. So, you know, you don't want to be low IGF-1, but conversely, high IGF-1 levels are associated with an increased rate of mortality, like we could say from cancer, aforementioned. So, you could compare it to like a real simple example would be like AMPK and mTOR pathways. Is like, hey, we could like sip EAAs all day and maybe maximally drive muscle protein synthetic response, or at least continue it, but then we're not activating AMPK at all, never accessing any. You know, there's a reason why animal models live longer when they're on calorie deficits. There's ultimately going to be a price to pay in terms of lifespan, especially for people that are trying to be bigger, etc. So where your ethics allow you to sit in terms of what it's worth to you is going to be the same consideration with growth hormone as it will testosterone or other performance enhancing drugs, you know?
Gotcha.
That would be my advice, I think. Just it's that low IGF-1, low growth hormone serum is a bad thing. Maybe mid-physiological upper range, yeah, pretty good. Above that, you're going to start seeing some problems. There
you go. This is probably one that I'll probably want, like you said, to have in the clinical range. There's a lot of these other hormones that we're saying, super physiological, and what is really super physiological, but this is one you probably want to be a little bit more careful with. Anything else you want to touch on? Or do you think we covered pretty much the whole slew of things at this point?
You tell me, man. I know you did do a thread on Facebook. Admittedly, I didn't look at the questions. Was there any questions on that?
There was, and you know what? I'm realizing now that someone asked me a question about that, and here I am completely unprepared. So if I see if I can find it really quick.
I could probably pull that up on my Facebook.
Jeffery. How professional is this, guys? Recording a video on YouTube, and I'm like, I'm on my phone.
Bro, it's a lot more professional than my podcast, so you're good.
You know, I'm not even finding the damn thing.
If I go on your profile, it'll probably come up.
Yeah, because I tagged you in it, right?
Yeah. Let me look on this.
This is riveting stuff, guys. Riveting stuff.
Let me see. Yeah, I've got one. There was a few questions on it. Would love to know more about growth hormone and if T4, T3 needed to supplement due to poor conversion issues.
Yes, I remember that one. Actually, it's true. Yeah.
Okay, yeah, that's quite a good one. So growth hormone does increase the deiodine. I can never say this word. Deiodination of T4 to T3. So that will drop T4 and increase T3. So it would make sense on that single snippet of information for us to use T4, right? However, this is only transient in nature. Long-term studies do show that this effect returns to normal in time.
Mm-hmm.
So hyper and hypothyroid states are associated with suppressed IGF levels. So you really want to be at a euthyroid state. So I'd say no, you don't really need to supplement with anything unless outside of your growth hormone use you have thyroidal axis issues.
Now I know why I didn't find it, because I didn't post it in the Facebook group. I posted it on my profile page
Your
by
profile,
accident.
yeah.
Yeah, because I went through the yeah. Okay, so here we go. That's why you saw it. What's the risk of shutting down your own production? Risk of insulin resistance? Risk of bone organ growth? What is an effective dose where you see these benefits would possibly mitigate risks? Well, we kind of touched on that.
I think we did
already.
All of that.
Yeah. Combining GH with IGF-1.
Okay.
Yeah, I was reading Suzanne Summers' new book, and she talks about this cocktail that she takes daily, combining GH with IGF-1, and she takes something called thymosin alpha-1.
Okay, admittedly, I don't know who Suzanne Summers is, so I can't comment on any of that. But growth hormone with IGF-1. So if you're going to inject IGF-1, you'd need IGF binding protein 3 also, so for it to be able to travel beyond the injected tissues. So the potential problem here is that IGF binding protein saturation will be reached pretty fast, and then you'll have unbound IGF-1 floating around, and unbound IGF-1 is labile, it's less mobile, has a lower affinity of binding to IGF-1 receptors. And it's worth considering that IGF-1 can cross-bind as well. You know, it could bind at an insulin receptor, which you wouldn't really want. And really, you want it to bind to a local IGF-1 receptor, like we spoke about the difference between autocrine, paracrine, systemic IGF-1. You want as much localized IGF-1 if you want maximum hypertrophy potential. So maybe if you got IGF-1 with IGF binding protein 3 in it, I know one product's called iPlex that makes that. Maybe that would be fine, but it's just it's not going to bring you any additional benefit over just using testosterone, growth hormone, insulin anyway. It's going to be ridiculously more expensive. And you know, think about this unbound IGF-1. So organs and your intestines have a high density of IGF-1 receptors. The last thing you want is IGF-1 floating around and binding at your organs or your intestines. You want it in the muscle. So I wouldn't personally see any efficacy of doing this.
Okay. And one last question from Gil in our Facebook group. He says he's talked before about ibutamoren having a bigger impact on IR than other IGF analogs. Does this have anything to do with it being a ghrelin agonist? And if not, what is the mechanism?
I have no idea. I just know that it happens. Trust me, I've tried to find out. If anybody listening to this does know, let me know, because I've consulted with maybe 50 plus people that have taken ibutamoren and their blood glucose have gone up usually between 5 to 20 milligrams per deciliter with the use of it, which is way higher than an equivalent dose of growth hormone in terms of the localized IGF-1 produced. I mean, I can hypothesize this. Maybe the active life is just extremely long, and I'm not sure if it is a bleed effect or how it drives IGF-1 there. I don't know. I just know that it does, which is why I tend to stay away from it. The literature, there's not loads of literature on it yet. Obviously, it's still a research chemical. Again, it's one of those things that I don't see a lot of efficacy using because due to the active life of it, it makes it impossible to really dose for either hypertrophy or fat loss considerations when you get into sort of the optimal way that you would want localized IGF-1 to be produced around maybe food. Like we said, you wouldn't really use it for fat loss because 24-hour plus active life, you know, unless you're fasting 24 hours a day, it's not great for that.
Mm-hmm.
It's just, I don't know. I just don't really like it on the surface of what it does. But if anybody does know why it does that, let me know, because I'd love to know. I don't think it's got anything to do with ghrelin. I can't see why ghrelin would do anything there.
So any of you guys do, they're watching, just throw a comment in on this video.
Yeah, let me know. Just maybe attach a reference and let me know why. Because I'd love to know. I've like desperately looked as well, because I've been asked that question a lot and I don't know, to be honest.
Sometimes saying I don't know is the best answer.
Well, yeah, I try not. I wouldn't want to, like, you know, make stuff up like, yeah, it's because of this, and then like it's completely wrong. I feel like if you're gonna say something, at least provide a reference. And when you are wrong, I would always say, I don't know, but I'm gonna go and find out. And I would say that, but I've tried and I can't find it.
Yeah,
You know, so that's
exactly.
that.
Cool, guys. If you like this video, like it, because we like to see when you like the videos, because then we're gonna do more. Because if you don't like it, then we're gonna say, well, you know, we're not gonna bother. Click subscribe if you haven't already. Click that notification bell so when videos come out, you're gonna get notified. We got all kinds of really cool cats like Joe Jeffery coming on to discuss a ton of different topics in every way, shape, or form you can think of. Joe, it was great having you. I know you weren't feeling well, and you were like, "No, I'm coming anyway." So that was really cool, and hope you enjoyed the rest of your weekend.
You too, man. Thank you very much for having me. Thank you, anybody that's listened this far. If you want to get in touch with me, it's just Joe Jeffery on Facebook or Joe Jeffery UK on Instagram. Jeffrey is spelled Jefffery, not REY. It's a strange spelling. So, yeah, just hit me up on there. Drop me a DM, and I'll do my best to get back to you.
Perfect. Anything else in regards to social media, or does that pretty much cover the gamut of
yeah,
it?
I do have a podcast. I have a podcast called Optimal Physique Development. You can just search Optimal Physique Development on iTunes. It's with Austin Stout, who's an awesome coach from the US, and we've done literally every episode on everything, and dig real deep on some biochemistry stuff. If you want to check that out, or on my Instagram, I have a little thing called a link tree in my bio. That's got a link to lots of different podcasts that I've done. Again, a lot of sort of biochemistry nerdy stuff if you want to dig into that. And if you can't find any podcasts, because we have done loads, just let me know and I'll dig it out for you.
Cool. Thank you very much.
Thank you.
Appreciate it.
Anytime, man. It's good fun.